Okay, why don't we, okay, I want to reconvene the House. The first thing we're going to do, we're going to take a few things a little out of order here. I'm going to have Lauren Carruth talk about the annual meeting and give us the annual meeting report for sake of time.
Good morning. As chair of this year's Scientific Assembly, I would like to welcome you to Atlantic City and Caesars Atlantic City Hotel. We have worked hard to ensure you have a setting where you can connect with friends and colleagues while continuing your professional development. During the next few days, you will be able to learn from experts and leaders from within the state and around the country, and we hope leave with renewed enthusiasm for the practice of family medicine. Thursday was our Practice Transformation Learning event, making the case for value-based care. During this session, experts in practice transformation shared their experiences with transforming the way healthcare is delivered. The town hall meeting on Thursday evening was a fireside chat with AAFP Director Dr. John Cullen. Here at the House of Delegates is our opportunity to voice our concerns, share ideas, and engage in problem-solving discussions on the issues that affect family medicine in the state of New Jersey. During this time, you will also be electing new members for the Board of Trustees, as well as the 2017-2018 officers. I want to thank you for your active participation in the House of Delegates, and I hope you are inspired to engage other members to become more involved with the Academy in the future. This year's faculty for the Scientific Assembly is comprised of experts in their respective fields, and we are excited to have them with us. You will learn more about value-based care, the importance of diabetes self-management education, anti-inflammatory diets, and opioids and addiction. We will have updates on basic medical topics on irritable bowel syndrome, atopic dermatitis, palliative care, smoking cessation, COPD and asthma, and other relevant topics. We continue our partnership with the state to improve vaccination rates. Aside from a presentation on the importance of vaccines, we are also featuring roundtable discussions on the exhibit floor where family physicians and infectious disease experts share case studies related to teen vaccination. We are also conducting our first ABFM KSA work group. There is still time to sign up and earn an additional 8 credits for participating. We are also hosting a motivational interviewing workshop. Stop at the registration desk if you would like to register for these events. One last event I'm excited to share with you is Echo Sunday. This partnership between NJAFP and Robert Wood Johnson Partners features a hub-and-spoke knowledge-sharing network led by expert teams who use multi-point video conferencing to conduct virtual clinics with community providers. 2 Echo sessions will be held on Sunday, one on thyroid disorders and a second on hepatitis C. This is a very unique experience. If you'd like to contribute a case for discussion, you can go to njafp.org under the Education tab, click through the Scientific Assembly, and then to Echo Sunday. You'll find links to submit a case. And don't forget to stop by the poster displays and attend the exhibitors' reception and resident knowledge bowl, all of which are part of what makes this meeting unique. Saturday night is the President's Gala. I hope that you will all be there to recognize the installation of the new board members and officers you will elect today, and to celebrate the installation of Dr. Peter Carrazone as he begins his term as our president. At the gala, we will also be presenting many prestigious awards such as the Family Physician of the Year, the Family Medicine Resident of the Year, and the NJAFP Chair Award. There are many companies and organizations who support this annual event. This includes our exhibitors and sponsors and companies that provide educational grants. Many of them have booths on the exhibit floor. Please thank them by visiting the booths during your break times and attending the exhibitors' reception this evening. I would also like to thank Caesars Atlantic City for their wonderful hospitality. Don't forget to download the mobile app and use it throughout the meeting. This is where you can complete your evaluations and provide feedback on the meeting. This will be a great help to Dr. Simonelli as she chairs next year's conference. Finally, it has been an honor to work with our Academy staff on this year's assembly. Please be sure to take an opportunity to thank our wonderful staff and when you see them. Without them, this meeting would not be possible. Thank you.
Thank you, Lauren. On behalf of the leadership and the House and all the members who are going to attend this, the Scientific Assembly this year, I'd like to recognize Dr. Carruth for her hard work in this venture. Those of us who have been involved at the level that she was involved in planning this meeting, at times, it's a thankless job. I mean, you get blamed for everything from the exhibitors to, the presentations to the fact that your toilet overflowed in your room. So, I want to thank her for all the hard work that she has done with the staff, and look forward to her in the future. Okay, so now we're going to get to the election of officers and board trustees. The bios are in the packet, and I will accept the report of the nominating committee. Aditi?
Mr. Speaker, from the nomination committee for the position of president-elect, we have Dr. Lauren Carruth. For the position of Vice President, we have Dr. Maria Simonelli. For the position of Treasurer, we have Dr. Michael Cascarina. For the position of Secretary, we have Dr. Kelly Assery-Kronhaus. Now, these are for the board positions. For the positions for the Board of Trustees, we have Dr. Donna Kaminsky. We have Dr. Anthony Miko. We have Dr. Jeffrey Rosenberg. For the position of new physician trustee, we have Dr. Jacqueline Yasik. For the position of AAFP delegate, we have Dr. Mary Campagnolo. And for the position of AAFP alternate delegate, we have Dr. Salvatore Bernardo. Those are the nominations from the nomination committee.
Thank you, Aditi. Are there any additional nominations from the floor? Anybody want to run from the board? Anyone want to nominate a friend or an enemy of theirs for the board? Okay. Anybody want to make a motion to close the nominations? Okay. And anybody want to second that? That's great. Okay. Perfect. So, as I understand it, hands were raised for that. So by way of acclamation, you have elected your board and your officers. Okay, the election of the nominating committee. Historically, we rotate the counties in the state for being on the nominating committee that works with the chairman of the nominating committee for that job. And this year, the lucky winners are Atlantic Cape May. So, Stephen, would you serve? Okay, so we have Dr. Nerkowitz. And from Cumberland County, where is Cumberland? Cumberland is at the empty space. Anybody know anybody from Cumberland County? Do we have anybody? We have members from Cumberland County.
Yeah, but if you're asking me off the top of my head.
Oh, no, that's fine. Okay, so Essex County. Who's here from Essex today? Tom Ortiz was somewhere. He's elected. You're not here, you get elected. That'll teach you. Attaboy, I'm in. All right, so we got Tom, we got Steve, and maybe we'll be able to find a member from Cumberland County to, not now, not today, some other time, but certainly, maybe they want to be active, as our illustrious secretary who's still here pointed out, people want to be more active in the academy, so let's reach out and see if they want to do it. Works for me. Okay, so they will comprise the nominating committee for next year for the slate of candidates. Anybody who's looking to run for the board next year, there's Tom Ortiz. Tom, you have been elected to the nominating committee for next year. You're welcome. Anyone who wants to run for the board or knows of anybody, again, as Mike said, that's interested in getting involved in the academy and is waiting for us to reach out as opposed to them, please let them know. They don't have to make that decision now, but it would certainly be nice if, we could get some other family physicians involved, perhaps, particularly with all the discourse going on out there nowadays in medicine in general. Okay, so, here comes the fun time. All right, so We're going to have the presentation of the resolutions. What time is it, Ray? 10, okay. And then why don't we... Never mind. Why don't we... You want to do a couple of... You know what? It's my prerogative. I'm the speaker. What the heck? All right. So we're going to start with the resolutions. And we'll get through a couple of them, depending on how contentious they may be, before we break for lunch. Okay. Correct. There is an emergency resolution on the website, courtesy of Dr. Ortiz. It is on the website. You'd have to refresh your browser to get to it. And that one is being considered as we move forward. So if we can get the first resolution, well, why don't we hold on that for a little while. Let's go to the first one in the packet. Okay, so resolution number 1 was proposed by Dr. Peter Carazone, so I will have him approach the microphone, read the resolves, and we can have a discussion. He's going out there. That's wonderful.
Just a quick background of how this came about. It's for physicians that are going to the hospital are very aware that if you admit somebody, before you can get them to a post-acute care, they have to be there 3 nights. I've run into a number of problems where I have someone coming in that's stable the first day to go, may not meet criteria to stay in the hospital for those 3 nights, and so can't get to the subacute, and it's created a lot of problems for the hospital practicing physicians. So be it resolved that the New Jersey Academy of Family Practice present a resolution to the AAFP Congress of Delegates or letter to the AAFP Board requesting that the AAFP engage in a dialogue with CMS in an effort to modify or eliminate the 3 midnight rule in cases where the patient requires discharge to subacute care but does not require hospitalization to the extent required by the rule. Next.
And you speak to that. It's your resolution. You speak to it, yes.
Obviously, I'm in
You're
favor.
in favor of the resolution?
I'm in favor of my own resolution, yes.
Okay, thank you. It is. So do you have anything else to add to that before others discuss, or we're good with that with you?
No, I'm good with that part, yeah.
Perfect, okay. So we'll have discussion on resolution number 1. Mary?
Mary Campanello. Another time today, history's repeating itself, but I actually brought the same resolution here. It's probably been 5 or 6 years which we passed. I'm sorry I didn't see this handbook until today, but so it is probably current policy that we have already. I definitely support it. I think, as Peter said, there's definitely patients that are disadvantaged by this system, and the reason I brought it a few years ago was a patient who didn't meet those criteria, was sent home from the hospital, and then she called me up and said, I have all the money I need to stay in the subacute, and she actually paid out of pocket to go back when she should have really been covered by Medicare, but she successfully transitioned through subacute and was able to go home again, and she's still home. So I support this. I know that the AFP has actually taken this on, and it's, unfortunately, as Dr. Collins said earlier, the CMS and the government in general has not been so efficient the past few years in running for the new election of a new president and all the other things that are happening, and so it's moving probably very slowly, and we should remind everybody that this is an issue still out there. So, but it might be good if we can talk to Dr. Cullen at some point about where we are with the AFP in this process, if he knows.
Okay, I think after we're done with all the members that wish to speak, I'll ask Dr. Cullen possibly to update us on what the AFP is actually doing.
Thanks, Arnie Pelley. I rise to support this, but I wanted to make an interesting observation that some of the newer at-risk ACOs are permitting a carve-out of the 3 midnight rule, and so a waiver, as it were. Yeah, so it's kind of fascinating that apparently there is an allowance for CMS to do this, and so I think this resolution is timely and appropriate, but it's kind of an odd event that they allow this in their own rules for certain entities like these at-risk ACOs, but they do not allow it, generally speaking. And if, John, if you have more to comment, I'll give the mic to you, but I do support this.
I support the. This is John Tabashnik from Union. I'm part of a next-gen ACO, and we do have a waiver for the 3-day rule. We can even admit directly to subacute from the office if necessary. So obviously, the CMS is thinking about this and is, I guess, trialing it in a few places. But I support the resolution. I think it's a good idea. We've been very successful with this.
Now, John, just a point of clarification. Is that also with the commercial insurers, the waiver?
It's Medicare waiver.
Well, the commercial, okay.
Yeah.
Commercial also has that 3-day sleep rule for the most part, particularly with Medicare. Well, not necessarily Medicare managed care, but I'm sorry.
Yeah.
Okay.
Anyone who's in our next-gen ACO is actually eligible for this 3-day waiver. So it probably includes some commercial as well.
That's great. Okay. Thanks, John.
Hi, Bob Spear, Middlesex. I'm speaking in favor of it also. Some of the commercial Medicares don't hold that 3-day rule. And you should remember also acute rehab isn't necessary to be in 3 days either. And I ran into one patient whose secondary was willing to pay for them to go without the 3 days. So there are some exceptions currently, but certainly I'm in favor of getting away from this.
Great. Thanks, Bob. Dr. Cullen, would you like to speak to any of the most recent initiatives of the Academy towards this resolution?
As I remember, because I had spent some time on the Advocacy Commission, and we did send a letter to CMS regarding this a few years ago. That's not to say that you shouldn't put it back in again. Sometimes it's a matter of just saying it again and louder. It's not a bad idea. And even if it's accepted for information, that doesn't mean that it doesn't have an impact. But this is something that we've been approaching CMS about.
Okay, thanks. So Peter, as I understand the resolve, there's two choices here. You have presenting it to the AFP Congress delegates or a letter to the board. Was there something you wish to both? Do you want to do one or the other, or there's an or in there?
One other thought is, because I'm getting new information that I didn't have when I wrote this, is to maybe make a little subcommittee to tweak this a little bit. Some of the things that could be in the resolve is there are exceptions, and we would like to see no exception. Everyone should be the same, and not certain exceptions to this rule. And in terms of a letter, I'll be in favor of, well, it's a letter to the AFP board requesting. I was just told to refer it to the board for discussion.
To our board?
Yes.
I got you. Okay. Because I was looking to see whether you wanted to add an amendment to that or where we're at. Okay, so so we are amending this. We're amending this to refer to the board. Is that correct? That'll be the action, yeah. Okay. Well, I'm waiting for that. Yes. Dr. Campagnolo.
Yeah, I'd like to make that motion to refer this to the board for further discussion and modification.
Perfect. Do we have a second to that motion? Thank you. Is there any discussion of that motion to refer this resolution to the board at the NJFP level? Okay, so everyone in favor of the resolution, raise your hands. Very nice. Those opposed? Undecideds? Abstentions? Very good. Thank you. You have that in then? Okay, so the second resolution was brought up by Dr. Sarah Darian. So I will ask Kathy to approach the microphone and read the resolves and discussion.
Resolve that the NJAFP Board of Trustees be tasked with working with the regional offices of the major laboratories in New Jersey, example LabCorp Quest, the state HIE, and any state-level government authority to work towards seamless exchange of laboratory data between any members of the patient care team that requests this data, and where necessary, a method for non-ordering physicians to request this data, and also be it resolved that all members of the patient care team be able to receive any lab results they have requested through the provider's usual preferred method of receiving results, for example, interface, fax, printer, mail, and also be it resolved that the NJAFP advocate that process of exchanging laboratory data between the care team and potentially to non-ordering physicians be done at no further cost to the medical providers, and be it further resolved that the NJFP present a similar resolution requesting that the major national laboratories be required to allow seamless exchange of lab test results among all members of the patient care team, requesting them through their usual preferred method of receiving results, whether or not the care team member was the ordering physician, to the AAFP COD for this cooperation to be sought at a national level, with the national laboratory offices mandating cooperation at the regional level.
Would you like to take a breath before you discuss this now?
Does it? I think so, yeah. And I speak in favor of this resolution. I know last year there was a similar resolution presented to the AAFP that got declined because people said that they would get too many labs. They get labs they don't want to see, then they're responsible for the lab if they see it and they get it, and so the whole thing got tabled. So I try to rewrite this resolution so doctors have an option to opt in to this exchange of lab data and not have it be automatic.
Perfect. Thank you. Any discussion on the resolution?
Paolo, a couple of comments. So first of all, in a friendly way, possibly amending this, I would consider that all labs, be they national or regional, certainly, Kathy, should have the same recommendation and guidelines. So I don't think we should specify major labs because they all should follow the same guidelines. So that's the first comment.
Okay, so you're amending which one of the four resolves?
So I would be saying that, change to all certified laboratories. And nothing against naming LabCorp and Quest, but I don't think it's relevant to the name of the lab. If it's a certified lab, they should follow the guidelines. And the only other area I would consider amending in a friendly way, Kathy, is in regards to HIPAA guidelines. Certainly labs get very fuzzy about providing information to non-ordering providers, and so it just needs to be clear to all these labs that provided all HIPAA requirements are met, the release of information to another provider, physician, or whatever is appropriate. And I think I saw that maybe in the second. I don't know if it's clearly written the way I would.
Okay.
Non-ordering physicians to request this data in a HIPAA-compliant fashion, something to that effect, to make it clear. Because it's always an issue. Everyone knows around this room that's always difficult when you get a subspecialist ordering something, you try to get the result. It's almost dependent, I find, on who answers the phone, whether they release that. They might not. Sometimes you get the patient on the phone. Sometimes they make you sign a quick release. That's a technicality which is appropriate, but the point Kathy's making is appropriate that we do that and get that exchange.
Okay,
Thanks.
so you're proposing that amendment. Do I hear a second?
Two pieces. There's two actually.
Two pieces
Two should be voted on.
an amendment, yes. Do I hear a second on those amendments? Very nice, good. Now, discussion on the resolutions as amended, the amendment to the resolutions. Hearing none, all those in favor of the amendment to the resolution. Were you rising, Dr. Ortiz, too? Okay. I'm sorry. Yes, Vic. Go ahead.
With the HIPAA compliance, I think, don't we already have that if the patient signs a form and then the lab releases those results anyways? I thought this was more that it should be much more easily accessible. If you're using a HIPAA compliant platform or you're basically logging into that website or you're just asking them, then you don't have to jump through the other hoops that, the patient has to sign, you have to send the request. That's already being done. So I kind of wanted a little more clarification on that.
Right. Okay. So you're calling for clarification. Kathy, did you want to clarify that, or Arnie, or Mary, or?
I was going to speak to Arnie's second amended. I know what he was trying to say, that the language of non-ordering physician is a little vague. So I'm going to recommend an amendment to change non-ordering physician.
Nope, wait a minute.
Sorry.
I believe that we have to vote on the
First
current
Amendment?
First Amendment before we go to a Second Amendment. I'm going to defer to my predecessor. I believe that would be the correct order. Okay, good. Sturgis has spoken. Okay. All right, so we'll have to hold that until that's all right. We're speaking about a clarification to the HIPAA compliance format and whether that makes it easier or more onerous to receive those tests.
First of all, just a quick typo. I think it probably should be HIPAA compliant format, but anyway, technicality.
Okay.
But I think it's important, just as we're going to communicate this to the AAFP COD, that the first thing people are going to say as a counter to this is that this could make it a wild, wild west type of thing where anybody's going online or calling and trying to get labs for people, and that we really do need to make sure that patient security and privacy is maintained too. So I think just putting that statement in that we recognize that important issue is important to do. And I'm supportive of the amendments and the whole resolution. And just to clarify, as we said in our report this morning, it really wasn't tabled last year. I think it was just accepted as current policy of AAFP. I think this does actually strengthen our position to get more action around it because it's more specific.
Okay. So, Victor, does that answer your question on clarification of the HIPAA compliance thing?
As I understand that we already get all the labs for any patient that we just have to request, and I thought this came about because it was a little bit complicated to have access to lab results for patients the ones we didn't order. So we have to send in a special request, which is HIPAA compliant request, to have access to those records, either to the lab or to the ordering physician. So after this, it seems like we're going back to be able to be doing the same thing. Maybe I'm not understanding correctly, but I don't see the real issue here if we have to do the same thing anyways.
Okay. Could anybody speak to that, Robert or Kathy? Okay. We're speaking to the amendment now.
I'm speaking to...
Clarification?
Yes, about, yes, if we make several phone calls and requests, we can sometimes get doctors to fax the results of the tests that they had after the patient has left the office, and with great difficulty. I am not a HIPAA expert, but I believe HIPAA allows for all members of the care team to exchange data openly, and you don't even need special consent. So I think if the patient identifies you as being a member of their care team, the lab should be able to just send the info. Right now, I can get it from LabCorp, but the format is horrible and it's on paper, and I have to manually enter it into my EMR instead of being able to get it through my interface. And I can't get it at all from Quest. There's no way for me to request lab work somebody else has ordered. And those are the two major labs I work with. The hospital, yeah, I can go on the portal and get any lab work anybody has ordered. But that's what this resolution is about. I should be able to get all LabCorp results through my interface so I don't have to manually enter them. And I should be able to get labs that the rheumatologist ordered on my patient through Quest without having to make 5 phone calls.
Okay. Thank you. Robert?
I speak in favor of this also. The hassle is tremendous for us as well. Now, there is a regional system in Middlesex County. It's called Relay Health. And if you're a member of that and the other organizations are members of that, I can go in, find my patient, and find any of the labs done at any of the hospitals or participating laboratories. And there was a push by the government to set these regional hubs up so that I didn't have to interface with each one of the places. And to a certain extent, that's working. It should be available in other counties as well.
Thank you for the information. Yes, sir.
George, I just 2 points. Point number 1 is the lab sometimes sends the patient the result before it goes to the doctor. And number two is any kind of coordination between different doctors who take care of the patient to do the lab, and it's done only few times a year rather than every subspecialty will order lab, which is the doctor did it. So,
Okay, perfect.
And then you draw blood, 6 tube bloods. You go to the lab, and then you go to the doctor. Like PSA is not done because there's cardiology. Then, you have to order it again because the patient wants it.
Right.
Okay, thanks.
Thank you. Okay, so we're going to vote on the amendment here, as you see before you in red, and the crossed out of the LabCorp request, et cetera, to meet with the all-certified laboratories. Okay. All those in favor of the amendment to the resolution. This is the amendment, not the resolution. It's the amendment. Okay, aye. All those opposed? Undecideds? Perfect, that passes. Okay, so now we're going to speak to the resolution as a whole. Does anyone else have any other thoughts, concerns, challenges, stories? Okay, Victor?
Not opposing, but maybe to this, a good idea might be that we can. We can basically report that we are part of the team, and then that should automatically allow access. Kind of a check mark that I agree to this. I certify that I'm part of the care team, and that gives us quick access rather than, in some way the lab should allow. I think that'll probably be an easier way to get access to these labs, where we just sign a little electronic thing that says, I am this patient's care provider in one way, shape, or form.
So you're suggesting some sort of process to move this along?
Yeah.
Okay, thank you. Yes, sir. The microphone is up here. I also heard a possible second-order amendment to this. I don't know if that's still alive at this point, but go ahead.
Palais, Arnie, I speak in favor again, but I'm just interesting as I'm sitting back and taking a macro look at this. I wonder if, Kathy, your intention as the author is to sort of move in a direction, and I just bring this out for the House to discuss for a moment before we vote on it, almost like the vaccines, to have a central registry of laboratory, if it could be made. And I don't know, John, if you have any knowledge of this yourself. It's interesting if you could have a central repository of laboratory data with proper securities, et cetera, that would be a unique capability. So yes, the urologist could access the PSA, and yes, the cardiologist and the primary could sort of independently access lipid results, et cetera. Is that something that you're sort of almost thinking of in general, or is that too Machiavellian to think of that?
So Dr. Saradarian, Dr. Palais is questioning your intentions here.
My intentions?
Yes. So can we move forward with that? Thank you.
My intentions are I just want to get the results through my interface. So, I think that's what Bob was speaking of in Middlesex County, the HIE, and I know Relay Health. I work on Relay Health. I know I have to sign something with LabCorp to get them to put my labs on Relay Health, but I still won't get it through my interface. And, we've been forced to buy all this software, create all these interfaces, make all these changes, and the labs haven't changed a thing in the last 20 years. I think it's up to them to figure out how to do it. That's not our problem, but I think they need to be told to just do it. That's
Okay.
my intention.
Her intentions have been so stated. Marty, speaking for or against the resolution?
Speaking for the resolution. I echo Kathy's sentiments about, okay, there is a way that we can get the information, but then, okay, we've got it here, our EMR is here, the two are not talking. And typing that stuff in is a problem. And I happen to be with an EMR right now that doesn't allow me to put all the things in manually in the flow sheets. Okay? Anything that comes from the lab goes into the flow sheet, if it comes through the interface, even if it's some weird test that the oncologist or the rheumatologist ordered. But what I can type in freehand is the routine, normal stuff. So I don't have that. I can't put it in there. I can scan that page in, but I can't search it. If they force this, then I'd be able to have everything in there, not just the common stuff.
Thank you, Mark. Is there anybody else who speaks for or against the resolution, has an amendment on the resolution? Okay. So we're voting on, I'm sorry, Victor?
I am in favor of this, but at the same time, if, as Kathy mentioned last year, it was tabled. I mean, if the oncologist or somebody orders a test or the urologist orders a PSA and it shows up in my EMR and I'm more likely to miss it because now I'm going to get 10 times more lab results, I don't want that. I don't want data flowing into my EMR that I'm not asking for or I'm not ordering. I understand that I should be, if I'm looking for data, it should be easy to access, but the EMR, just because I'm part of the care team, shouldn't inundate my EMR.
Mm-hmm. Okay. Mary?
Vic raises a good point, and I don't think it would change my support or change anything in this right now, and maybe this will be something we should look at as we prepare to bring this to the AAFP if it's passed, but that really, in our own health system, we've had some experience with that recently where data does flow in from various people in our clinically integrated network, and it shows up in your EMR, and that's part of the challenge of the governance of integrated systems and HIEs as to the governance of who's responsible for what labs. And so that is something we're all going to have to take on in our own environments, I think, or maybe we'll have to figure out if there's some other national initiative around that, but I don't think we're quite at that point and able to do that right now. So I think we should still pass this, but that is an issue that we'll have to sort out, is there are going to be a lot of labs that come in that we didn't order, and then it is up to whoever did order them to address them if they're abnormal, or us to take that on and communicate with those people. So there is some work around it that we'll have to do.
So it's the old conundrum of we want it, but we don't want it. Okay. All right.
Well,
yeah, careful what you wish for, that too.
point of clarification, I remember that was the hot topic at National last year, which is why I wrote into the resolution only if the physician requests it, not an automatic downflow of all the data. It actually has to be requested by the physician.
Okay. Hence the process that Victor was speaking of earlier. Okay. Okay, so we have an action on this, Kathy. With all the resolves, it's just, are we sending this to the board? Are we sending this a letter to the board, the national? What was in the resolves? A resolution, okay. And then the AAFP delegates will take that to national. Yes, okay. So we're voting now on the resolution. All those in favor of the resolution as written at this point with the amendment, say, raise your hand, please. Okay, all opposed? Abstentions? Perfect, thank you. Where are we at here now? I'm going to take the prerogative right now to do some of the committee reports. We do have at least 3 other, maybe 4 resolutions. I'm going to put them on hold till after lunch so that, we have a good reason to come back at that time. So, hey, I'm the speaker. Rich said, whatever you want. This is New Jersey. All right, so I'm going to start with the committee report on the Committee on Communications. I believe Teresa has a extended report in your packet. Okay, if there's any questions, Ray said he could answer them. Tried to throw Claudine under the bus, but it's not working here. Are there any questions of Ray regarding the Communications Committee? Okay, so we accept that as written. Okay, now here's a contentious one. Maybe we can get through this by lunch. The Government Affairs Committee, and I know that's our own beloved Dr. Peter Carazone, And Claudine, I don't know who wants to go first, but the microphone is yours. Oh, I guess Claudine goes first. That's like a lateral, I think you did. So. All right, perfect.
You get to stay on his chair? Yes, that's good. Yeah, okay. I'm going to go backwards if I can, Mr. Speaker, just a little bit on the communications report. It's not just from Teresa's communications piece, it's also our public relations and social media aspect, and there's a good report from the PR firm in the communications report. And one of the things that I'd like to always compliment our group on is you guys are always available when the PR firm calls with a reporter who needs to talk to you. So I could always get one of the leadership, one of the board, Ray, myself obviously, to speak on the radio. I think, Peter, did one of you guys was on 101.5. So we've had a lot of opportunities, at least, they're reaching out to us. So the benefit of having the firm. Government affairs, switch gears, big report in your package. Opioids, and opioids. I guess that's my report. I was happy to see the membership survey when we went over it yesterday, because the focus of your advocacy on the opioids was not so much on the opioids, but the administrative aspect and the hassles related to the opioid policy. So we were in line with how the members were hoping you were spending your time on advocacy. The state is in disarray politically right now, so we have a new governor getting elected in the fall, and right now it's Murphy and Guadagno. She's the lieutenant governor currently. The legislature is going to be up. There is leadership battles going on. Nobody's getting along, and it's a mess. It's probably the worst I've seen in 20-something years. So Senate President's being challenged, the Speaker's being challenged, there's a lot going on. Where that is problematic is that they are focusing on a lot of little healthcare issues that they don't quite understand that have to do with the state health benefits program and other state-run programs. So we're kind of keeping my ear to the ground and making sure they don't mess anything up. The out-of-network issue has been going on. I'm sure you read all the articles about it. That is a hot issue that's going to get maybe resolved in the fall. So we've been kept out of it, but I'm always involved with the coalition of providers to make sure we're not pulled back in. So. Telehealth. Telehealth, there's been a bill pending for several sessions, and it's actually going to define telehealth in the state. It is going to authorize payment and payment parity for telehealth services. The big issue on the physician side was, with these companies coming in, that they make sure that the physicians that they're contracting with are licensed in the state, and that they establish a relationship with the person, and they have criteria for how to do that. I think the payment issue, while everyone's focused on telehealth in terms of using it in the ER or for psychiatry or some sort of access issue, it really is going to give your practices an opportunity to get paid for a lot of the stuff you do on the phone. So I think there's a lot of opportunity in that bill. So I think it'll probably be voted on this month and be signed. I don't see an issue with that. But Teledoc, Insight, and Telepsych, I think, are the three groups. And I think Teledoc works with Virtua currently. So, one of the pieces that is in the telemedicine bill, it would require the service, the Teledoc, the doc talking to you, to identify if you have a PCP and send a report to that PCP after they talk to you. It also, if they don't have a PCP, help you identify one. So I think I was talking to Peter or Dr. Itis, Dr. Corzone, about maybe connecting with Teledoc and those businesses and maybe being a resource, and JFP being a resource to help them identify the PCP in their area. So, perfect. Any questions?
Questions?
Claudine, one other question that came from our department members at our health system recently about the opioid change, the regulation, and we do appreciate all you did on NJFP website, and that was great information to give to our folks. But the question has been coming up, because I think you had mentioned it, and I believe MSNJ had too, that we were going to try to collate any instances of patients that were disadvantaged by the regulations. And I think there are a number of cases turning up where patients have been disadvantaged by surgeons who write 5 days worth of medicine and then say go to your PCP for follow-up. And so as those things are starting to arise, how are we going to get that data and put it together so we can bring it back to the state?
So we didn't do anything formally. I did talk to MSNJ. We were talking about maybe giving you guys some sort of form in your offices so that you can collect that information on your end and get it to us. I think I was getting a little bit of resistance on how that would go down, but I did, they do call MSNJ patients, and patients call me. And I thought it was kind of funny because as soon as the law was in effect, they must just Google prescribing 5-day supply law, and my summary for NJFP comes up, and I've been getting a lot of calls. Yeah, it was good. And a couple of them were in Senator Vitale's district. I sent them right to him. So we didn't do anything formal, and if you're coming up with them, and I would just say to everybody, protect the patient's identity, but send me those scenarios. And I think that that's a big issue. Obviously, the surgical 5-day, and the surgical specialties did try and get an exemption at least for 7 days, so at least gets through the weekend and maybe to their post-op appointment. And most of them wanted 14 days, like the thoracic surgeons. They don't get to see their patient kind of in 5 days. There are issues with the law that don't necessarily affect you guys with the pain management agreement requirement, because it says it has to be initiated upon the 3rd prescription, but as it doesn't talk about it being the consecutive prescription or the prescription from the same doc. So if someone in January has surgery, someone in June, something happens, and then they get a prescription in the fall, it would make you give them a pain agreement. It wasn't intended to be that way. We tried to change it beforehand, but Christy just wanted to kind of blow it through without changes. So our friend, Sharon Joyce, who is John's wife, Batchnick's wife, she's in charge of writing the regs, and I have the benefit of a 20-year relationship with her, so she kind of, works with me, and we get the language right, and she's writing a reg right now to fix it. So we're on top of it.
It's a little uncharacteristic of Governor Christie to blow things through. But having said that, I believe Dr. Liu had a great question on that. So if you would approach the microphone there, Doctor.
And the danger with Christie is he's bringing New Jersey's policy down there. So his flawed policy is being implemented down there. So,
And you also outed John Tabachnik's wife, so hopefully no one has your number, John. Could be a deluge.
That's okay.
Yeah.
Totally appropriate.
Oh, good. All right. It's fine by me.
Thank you, Speaker, and for your suggestion to bring that again. And I'm asking for all of your help to suggest 2 things, probably. Number one is we should have a rule that our assistant can check as well, because I'm constantly being pulled out, sign in and check and all that stuff. It's very disturbing to the practice. And secondly, to the nationwide level, to have a central collection center, data collection to protect us, because we went to the lawyer lecture on May 22nd, thanks to Sinclair, our chairman, very much so, to educate all of us that in Sinclair Department of Family Medicine and in general to doctors, that the lawyers seriously warned us if someone had positive marijuana, let's say, and you still give out the narcotics, and the state can suspend your license, and no one can defend you. That's what she says. And I freaked out because I don't know who actually had positive history of before marijuana or cocaine, because it's not posted anywhere that I can know. Will I be legally bound to that? I don't know. So I'm asking all of you to see whether we can make this a request to the legislature to implement like a red flag in the PMP program if that person, is positive for any recreation drugs.
Mm-hmm. Okay. Thank you. So, Claudine, the doctor is suggesting some additions to the PMP website that would help with those who do pain management.
So the only thing that I can think of that could be listed is if they got medical marijuana. That would be the only thing that the state would be able to include in the PMP. And I don't know if it is. It might be already because they have to do certain schedules. So I can look into that aspect as far as other drugs, and they're not going to have access to that. You know, do you understand? Yeah.
I just wanted to say, I think Dr. Liu has a good point, and that if somebody has a positive urine drug screen for any reason, potentially that there should be some way that some of these folks are flagged and they're not. We have to go through and kind of surmise if somebody's getting multiple drugs from different individuals, but there's nobody, and again, there's probably going to be civil liberties questions about some of that, but it still seems like it would help us if there's somebody who, especially now that we do have access to multiple states, that they would be flagged for having been, again, drug abusers before.
So, I'm just trying to understand. So you want to see that if they went to you and they had a positive drug scene that you didn't prescribe, and then they go to them and they don't.
And I discharge them for that reason,
right.
potentially.
Yeah. But you're not going to be they're not going to be. I'm not going to contradict an attorney's advice, but you're not going to be legally responsible if you prescribe someone that you didn't know had a condition or couldn't possibly know had an abuse or.
So a lot of doctors practice in groups, right? So you ordered it, someone else reviewed it when you're not there. So you're responsible, maybe. Who knows? I don't know. And there's a lot of a problem in practical terms that your license in danger. It's not fair. That's why I'm trying to say it's not fair. Yeah, I'm trying to see whether there's any way to protect doctors and not just putting us into jeopardy. And there's nothing that we did wrong, and why do we get punished?
So, Claudine, I'm going to sort of help you out a little bit here. I'm going to take the prerogative to ask our resident addiction specialist, Ken, if he would like to, avail us of some words of wisdom about the current challenges. Thank you, Ken.
I'm not sure you want to legislate office practice. Particularly in this field, because the spectrum of practice, just for drug screens in general, is very sporadic. Many physicians are using office-based CLIA wave drug screens that have false positive or false negative results. So you can't really use that. The best way to do this is to document in your medical records your decision-making process. And there's nothing, Claudine, I'm not sure there's anything I've seen in the regulations that say that if someone comes back with a positive drug screen down the road for a controlled, a recreational drug or an illicit drug, that you're going to be held liable for that as long as you have good medical records in your office documenting the fact that you've asked this, you screen them, you use an opioid tool for potential issues in relationship to that, significant psychiatric disorders, significant substance abuse disorders, family history of substance abuse disorders. I think if you document that pretty well, you're going to be protected. Remember that some of this is to protect the patients. And I wrote a little thing in Perspectives that, I'm not going to accept the responsibility for the opioid epidemic. And I don't think any of us should either. I think most of us here prescribe drugs and are fairly consistent, regular. When I see some of the drug prescribing patterns that come out where people are using 120 milligrams of oxycodone 4 times a day, I've never been anywhere close to that, and I'm sure most of you in the room have never been close to that at prescribing. But that's what's happening in some of these facilities that are pill pushers, essentially. So, I know that this is Christie's initiative right now, and certainly there should be some rules behind it, but I think we have to accept this as a sort of a monitoring process that we should have in place in our practices so that we do it sanely, logically, and have common sense. But I'm very, very fearful of putting more legislation into how you run your practice. So I think developing a doctor-patient relationship is really where you're going to protect yourself.
Thanks, Ken. Robert?
Robert Gorman. I think that your concerns about doctors getting into trouble, I think you're probably worrying about some things that we don't have to worry about. I think that the prescription drug monitoring program, if we follow those rules and we check it, there are 12 additional states that we can check by just clicking at the bottom of the screen, so all of the neighboring states and then some others. We're only really responsible for knowing that. We're not responsible for knowing the other stuff. You did mention that if a colleague refills a drug that you prescribe, that you could be in trouble. Well, that's true. But that's not a legislative issue. That's something for you and the colleague to make sure that you're on the same page. So there should be some understanding among practicing physicians that everybody understands the legal requirements of the new opiate law. And if everybody follows it, and you can get very good guidance from what Claudine puts on our website. We've used that, and I've shared that with other colleagues that are not family physicians. So if you follow those guidelines, you will not get in trouble with the law. One other point that you made about the inconvenience of having to check it, you can have a certified MA be a surrogate to check it. So if you haven't done that yet, you can empower some of your staff to also do that work. Yes. Yes. Right. The person has to be a certified medical assistant, and then you can assign them to be your surrogate. So they will be appended to your license. No, but it has to be a certified medical assistant. We don't really understand why. Those of us on the Government Affairs Committee recognize that anybody who works in our office who answers a phone has access to all of the information in our office, but for some reason the folks in Trenton were happier if it was a certified medical assistant. So you just need to make sure that they have their hours up to date and they're currently certified. And if they do and they have a certification number, then you can just apply for that and they are a surrogate to help you.
There's also an app that you can get on your phone. I don't know if it's working right now. It kind of comes and goes, but there is an app that I heard is very useful in case you can check. You want to check it? Yeah, it's I think it's NJPMP if you search it in the app store.
Okay. Anything else? Any new reports, earth-shattering issues, challenges? Dr. Carasone, you're going to speak later on a few things, possibly. Okay, good. All right, perfect. Thank you, Claudine. Appreciate your report. Claudine does a tremendous job, as those of us who've been around for a while know. I'm going to ask Ray to report on the membership committee, and then shortly after that we will break for lunch and then reconvene at 12:45 for the resident, student, new physician reports and the discussions on the rest of the resolutions. Ray?
As I am now the only thing between you and lunch, will be really quick. You have this report in your book. Our membership continues to grow. A couple of things that may be of interest to those of you who are interested in this type of thing. The student number goes up and down based on simply the timing, same as the resident. We always have 100% resident participation thanks to the residency directors. We have significant student representation because, well, it's free, and, you know, if you give somebody something for free, they'll probably take it. The real important part of the membership report, for those of you who get wonky, is you may notice there used to be 2 supporting categories. There's only 1 now. The AFP combined those. We can have long conversations about that if you'd like. And the active number continues to grow. I am pleased to say that I recall when I came here in 1999, that number was 723. I have very little to do with that, but it's still fun to look at. When we crossed the 1,000 line, we became a large chapter in the AAFP's parlance. That was really exciting. Put us on a par with Pennsylvania and Texas and California and all those folks. And AAFP immediately then created a very large chapter category for those folks so that we can keep chasing them. If you have any questions about membership, I'm happy to answer them. Otherwise, your lunch is in the same place that your breakfast was in this morning, the Diamond Club, and I will give it back to Dr. Schauer.
Okay, as Ray said, lunch is in the Diamond Club, but we'd like to reconvene at 12:45. We do have at least 3, possibly 4 more resolutions to discuss. 1 or 2 of them may be contentious, or at least everybody will have something to say about them. So thank you for your attention, and we'll see you at 12:45.